All right, we'll go ahead and get started then. Thank you all so much in the room for joining us tonight, and thank you to those online that have joined us via the webinar. Just 2 notes before I introduce our speaker. I really want to say a big thanks to the One Health Commission that allows us this webinar capability. So please, if you're attending online, consider supporting them. They make this possible. And also to ASM for hosting us in person and allowing us to come each month and provide you with this amazing opportunity to speak to these speakers and hear about all the information and learn about One Health. So thank you to both groups for having us and hosting the One Health Academy. I will get started with our intro. So Dr. Stephen Ault is a public health biologist who works in international public health. He did his undergrad degree at UC Davis and graduate studies principally at the Liverpool School of Tropical Medicine and UC Davis. His focus on control and elimination of tropical diseases and their vectors, global public health and environmental health, and has authored over 27 scientific publications. He was a co-recipient of the PAHO WHO 2010 Outstanding Team Award, Pan American Health Organization, World Health Organization for work on influenza A, H1N1, emergency response team to combat the H1N1 pandemic. Stephen retired from the World Health Organization, PAHO, in December 2015 after 19 years of service, where he recently had served as senior advisor for neglected infectious and tropical diseases. Previously, he has worked in California EPA and consulted with USAID, the World Bank, and APHA. Stephen now teaches part-time courses in epidemiology, global health, and health policy and planning at the School of Public Health, University of Maryland in College Park. Please join me in welcoming Dr. Stephen Ault. Thank you.
Oh, thank you very much for the very kind introduction. It was really delightful to hear both the depth and the breadth of experience of the members in the audience here, and I'm sure that those online have a similar breadth and depth of experience in One Health and in public health. So my first time here, I'm really grateful for the invitation, and I look forward to talking with you about a subject that I've been working on certainly for a number of years, and that is the elimination of certain types of communicable or infectious diseases with a focus in the Americas. I did spend nearly 20 years with the Pan American Health Organization, but prior to that, I actually worked in the USAID Environmental Health Project. His predecessor was WASH, I heard you mention that. And prior to that, also with California EPA, as was mentioned. I'm an entomologist, parasitologist, ecologist, a little bit of everything, jack of all trades, master of none. But it's been helpful to be able to look with that perspective at the issues of infectious diseases and particularly their elimination. So I'll discuss some points in the theme of disease elimination and then talk with you about an activity that the Pan American Health Organization is getting underway, which I hope you'll find of interest. So I'll talk a little bit about communicable diseases or infectious diseases and Sustainable Development Goals. I'll mention some examples of diseases that are targeted for elimination, neglected tropical diseases or NTDs, and then I'll give an example of onchocerciasis or river blindness, which is normally not thought of as a One Health issue, but it's actually a very excellent model, I believe, for the question of how can one go about to structure and plan and carry out an elimination program for a tropical disease. And I'll also mention some work with human rabies and foot and mouth disease. I'll wrap up with some challenges in that area, and then I'll introduce you to the new Elimination Initiative of the Pan American Health Organization, which is the regional office of WHO for the Americas. Since my retirement from PAHO, I've been working in this theme as a consultant with PAHO, so we've worked together to construct what we hope will be a very important initiative from now through at least 2030. In terms of disease elimination in the Americas, one might say that the first initiative or stepping into the space of disease elimination was that of the fight against malaria and yellow fever in the Panama Canal Zone. Though, if I recall correctly, there was also some very important work in Texas and the Mexico border on elimination of tick-borne babesiosis, which I think was prior to this, and that too was an effort to eliminate a disease. But so this work of disease elimination, this topic has been in discussion for more than a century now. We see some old photographs here of digging the canal and spraying for anopheline vectors in the canal area. The Pan American Health Organization actually began as the Pan American Sanitary Bureau, and was established in 1902. And one of the first tasks of the bureau was to focus on this very issue of working to protect workers in the Panama Canal Zone as the canal was under construction. And you can see on the left here, there's a group of men being trained to effectively spray walls with residual insecticides for the killing off of anopheline vectors, which inhabit homes or enter homes. Also, you can see this very fascinating map of what the status of what was termed malaria eradication at the time. Malaria eradication in the Americas was in 1958, when I was just 6 years old. And you may notice that certainly malaria eradication was being targeted in parts of the US as well, in the Great Tennessee Valley, along the southeast coast, and even in the Central Valley of California, where Anopheles fribeni is today still a potential vector for human malaria. Now, much of the history of elimination of infectious disease elimination efforts has been based upon the great successes with respect to vaccine preventable diseases. And this is a timeline which just shows you the progress that has been made since the 1970s with respect to the elimination first of smallpox in the region, polio, wild polio virus, rubella, congenital rubella syndrome, measles, though this is a hot topic these days, whether the Americas is going to remain free of indigenous measles cases or not. And then more recently, it was possible for PAHO WHO to declare the elimination of rubella and congenital rubella syndrome in the Americas. Even more recently, the elimination of neonatal tetanus in the Americas. And the current work, among other topics with vaccine preventable diseases, is the elimination of perinatal hepatitis B. So with this history, the experience that the countries in the region have, as well as their partners, the CDC, PAHO WHO, USAID, and other institutions, it's been a successful geographic area to work on disease elimination. Now, the communicable disease elimination work is actually embedded in part of the UN's Sustainable Development Goals to take us to 2030. And as probably many of you have heard, there are a number of goals which are actually targeting the elimination of selected diseases by 2030. Embedded in goal number 3, looking at ending the epidemics of AIDS, tuberculosis, malaria, neglect of tropical diseases, and combating hepatitis, waterborne diseases, etc. So it's a very general group, but for each one, certainly work is being carried out based upon the successes and the tools we have at hand. And we also see that the World Health Organization in 2017 had established a flagship initiative for fast tracking to disease elimination. This is undergoing some changes now, but the theme is the same, that we as public health professionals and our partners, our colleagues, and our stakeholders need to work together towards this effort. Now, disease elimination is a term that gets often mixed up at least in the press, with eradication. We often see the term eradication being used when actually technically we'll refer to disease elimination. But I wanted to share with you this particular slide, which is the set of definitions that PAHO and WHO work with, particularly with respect to neglected tropical diseases, but also as a part of the general background for disease elimination. So I won't take you through these definitions, but I do want you to be aware that particularly we work intimately with two themes of elimination. Elimination as a public health problem, and also elimination of transmission. And for certain diseases, even in this region, eradication efforts have been carried out, and we hope to be, I think, formally verifying in the next 10 years that yaws, for instance, has been eradicated from this region. So just be aware of these definitions and the distinctions between them, particularly if you talk with the public, so that they will better understand the work that is carried out. Now, I think I'm sure everyone here has heard of the neglected tropical diseases, and certainly there are some common elements in this large basket of bacterial, viral, and parasitic diseases. And those commonalities stem around the fact that the populations that are most affected by these diseases in general are those that are living in poverty, or living in areas without adequate sanitation, access to safe water. And I highlighted here, with respect to the One Health theme, in close contact with infectious vectors and domestic animals and livestock. And another commonality is that these populations also typically lack access to healthcare services, primary healthcare, and certainly secondary and tertiary healthcare as well. So within these communities, living in poverty, living in geographic isolation, there are great challenges to address the NTDs in their environment, and to work on elimination of several of them. NTDs also exist in the USA as well. We have Chagas disease as I think a very interesting example, where more and more evidence of local transmission, and certainly individuals infected in Texas is under investigation and in discussion. The current portfolio of NTDs that WHO is working with is shown here. There are 20 of them, and I highlighted in yellow here those which are being targeted by PAHO as those that can be or potentially can be eliminated, either as a public health problem or in some cases the elimination of transmission. And so you can see the list. The list is diverse. I did mention yaws in this region, which there has not been a case reported for 2 or 3 decades, but still the region will have to go through a process of verifying its eradication, which WHO is now working on to develop guidelines for that purpose. Now, I wanted to talk with you, as I mentioned, about river blindness, which is an interesting example for both the challenges and the successes that one can have in elimination programs. This is typical of the habitat for the black fly vector, the Samelium species in Latin America, which have transmitted river blindness or onchocerciasis for nearly 500 years, we believe, and certainly since it was discovered by Robles in Guatemala a little over a century ago. We've known of its distribution in a number of countries in the region. So fast-flowing streams, rivers, where the flies breed, and where the adult flies seek blood meals from humans, and where the parasite, as far as we can tell, was actually introduced from West Africa during the era of the slave trade, and has been in this region ever since. So it was an imported disease, as far as we can tell, imported to the region. And now we're very close to eliminating it after 500 years, and after about 30 years or more of very hard work by the endemic countries. I won't take you through the life cycle, but I just want to remind you that this is a parasitic infection where both the black fly and the human play a role in different stages of the life cycle of the parasite, and which, if untreated, can cause blindness in individuals who have been heavily parasitized through their lifetime. The pathology is not just limited to blindness, which I do show that in the lower right slides here of various individuals showing a progression of blindness, which is unfortunately irreversible. But also it's known to cause very severe skin scarring, skin malformation, and nodules like on the head of this child where the adult male and female worm live and grow and reproduce and circulate the microfilariae, the larval stage, in the bloodstream of the human, where the black fly picks it up during biting. Onchocerciasis is treated principally these days, and certainly in the last 30 years, with one particular medicine, ivermectin, particularly Mectizan, which is donated by Merck to all the endemic countries, and which has really been the keystone to the possibility of eliminating infection in humans and transmission by the black fly. Initially, with river blindness, it was thought that focus on control of the vector might be a successful way of stopping transmission and reaching elimination, but the experience in West Africa proved that over the long term that wasn't feasible. And fortunately, ivermectin was discovered as a very effective anti-parasitic agent for this disease, and really opened up the doorway to the possibility of breaking transmission and ending the disease. Now, in the Americas, the partnership, which has been working with the 6 endemic countries since the late 1980s, is known as OEPA. The organization for the onchocerciasis elimination partnership, which has been working actively, as I say, with the 6 endemic countries. It's based in Guatemala, works closely with the Carter Center and all the partners, which I'll mention shortly. In the effort to eliminate onchocerciasis, we show here the various stages of the elimination process, where treatment with ivermectin begins in a population endemic for the disease, and taking the medicine results in the suppression of transmission, a decline in the adult worm population, those nodules that I mentioned in the skin. So we eventually reach a point where transmission is suppressed, and this can take from 4 to 14 or even more years. So it's been a very long bit of work for countries, particularly if they were not able to deliver the medicine at every population at risk at sufficient frequency. So that's why the program has been going on for more than 30 years, but with great success, as we'll see. Once the population of parasites, particularly in the blood, the microfilariae, it reaches a point where a black fly biting an individual can no longer pick up microfilariae and then let the parasite go through its life cycle in the fly and then bite another individual, then we reach that point where transmission is interrupted. And under the guidelines that WHO has set, written guidelines, there's a 3 to 5 year period in which it has to be determined that indeed transmission of the parasite is interrupted, that we do not find flies, larval stages of the parasites in Simulium, and of course that the evidence of infection of particularly of young children is no longer occurring. And then once a country has been able to meet the criteria of having interrupted transmission, an international a team organized by WHO is set up, made up of experts who go through a process of verifying that indeed transmission has been eliminated. And after a large dossier is prepared by the country, evaluated by the team, country visits are made, at least one country visit made by the team, and other information is put together. The team can recommend to WHO that indeed there's no more evidence of transmission of this parasite in the given country in any of the populations that were at risk. And WHO can issue a letter of verification of the elimination of transmission. And that comes with instructions for the country. The country goes into a post-elimination surveillance, PES period, which is indefinite. The letter may state that it must go on for a number of years, but generally the message to the country is that though transmission is eliminated, you certainly still have the black fly. There's a possibility perhaps that the parasite may be imported once again from another country. So post elimination surveillance needs to continue for an indefinite period. Now, in 2001, you can see here that there were 13 foci of transmission of onchocerciasis in the region, extended in 6 different countries: Brazil, Venezuela, Ecuador, Colombia, Guatemala, and Mexico. And at that time, transmission was continuing in each one of these 13 foci. The elimination program is described here in terms of what it took and what it takes to carry out a successful elimination program: political and financial commitment, human resources, health education, the availability of the drug ivermectin, which is distributed in mass to the population at risk, and then that post-treatment surveillance period, and all with the collaboration of partners. So today, in 2018, 2019, we see that transmission is ended in 4 countries, and only the southern focus in Venezuela and the northern focus in Brazil are where we still have evidence of onchocerciasis transmission, though in general at a fairly low level at this point. So only 6% of the population that was at risk continues to be at risk. And the possibility of eliminating this disease from the region is very close. This is a picture of a motor launch in Ecuador traveling upriver to visits of villages where river blindness or onchocerciasis was transmitted. It flies the UN flag because there are lots of one of the challenges of the onchocerciasis program and many other disease elimination programs. There are risks of violence, of criminal gangs, being stopped by the military who are guarding their borders and their interior, And all this necessitates that a group of people like this on the river, has a reason for being there. Now, onchocerciasis and its elimination depends upon the distribution of ivermectin, which should be, under ideal circumstances, delivered 4 times a year to the population at risk. And these populations are very diverse. The foci that are left now are principally in the Yanomami population of southern Venezuela and northern Brazil. And that is pictured in the upper right, a group of Yanomami and returning to their village. But the disease had also been endemic in Mexico and Guatemala, and in Ecuador, in indigenous populations, and some other groups. In Colombia, it was principally in an Afro-descendant population that lived in the interior of the country. But in every case, it's necessary to work with the local communities, their community health workers, to make sure that everyone who needs the medicine receives it 4 times a year, and all the challenges that goes with that. So it takes a village in that sense, and it also takes partners. So when the partnership, OEPA was established, the partners that were involved and are involved to this day are Merck, which provides the ivermectin free of charge, CDC, Lions Club, the Carter Center with its executing group, OEPA. The Gates Foundation has supported this work, PAHO, WHO, and various NGOs and others. And working in collaboration with the ministries of health of the 6 endemic countries. So it takes a village, and it takes these partners to reach the success that we've seen in the region, and gives us guidance on what can be done if the resources and the will are there. Now, I'd like to mention a couple of other diseases, infections, which are also targeted for elimination. In the case of rabies, we see in the region, the graph on the left shows the continuing decline of reported cases of human rabies transmitted by dogs, by canines, over the last more than 20 years. And you can see in the map on the right, during the last approximately 12-month period, March of last year through February of this year, we've seen only 5 reports of 5 cases of human rabies transmitted by dogs in Haiti and the Dominican Republic. So if this can be maintained, and if these 2 countries can continue to work together and finish the job, we may see that rabies, human cases of rabies transmitted by dogs will come to an end in this region. This is basically another view of those 5 cases which we've seen in the last year, a very low number indeed. And also the few number of cases of human rabies derived from wild animals, with contact with wild animals in the Latin American, in the Caribbean region. So just nine cases of human rabies in Brazil. And we've got 2 in Mexico, and 1 each in Dominican Republic and Costa Rica. So again, human rabies may be on the way out in the region, but continual efforts, including, of course, the dog vaccination campaigns, must continue. For rabies elimination, the partners that PAHO works with, particularly its specialized center known as Pathophysiology, based in Rio de Janeiro, works with this group of strategic partners for the elimination effort in this region, each contributing its own skills and resources, and coordinating to make sure that dogs are vaccinated and that a treatment is available for humans that are bitten by dogs suspected of having rabies. The organization, or the specialized center that works on this, Pathophysiology, actually was the center established to work on the elimination of hoof and mouth disease, or foot and mouth disease, in livestock, but rabies is placed within the purview of Pathophysiology with respect to coordinating this elimination effort with the countries in the region. I wanted to mention, certainly there's an immense literature on certainly rabies control, and more on rabies elimination, but I wanted to point out this very interesting program which focused on, this very interesting model for fostering collaboration, sustainable collaboration for rabies elimination, which was developed by a number of authors here and published just last year in PLOS NTDS. You won't be able to see the image very well, but I encourage you, if you're interested in this question of the sustainability of and the collaboration that is needed for infectious disease elimination programs such as rabies, I very much like this model, which takes us through a schematic in which the situation of rabies is evaluated in each country using protocols and algorithms and standardized procedures. Determinations are made, and then the capacity of the country to be able to actually work on the question of elimination, not just control, is also evaluated and discussed, whether they have a low, moderate, or high capacity as a nation, and what will it take to do the strengthening necessary so that all become high capacity and can contribute to elimination of human rabies transmitted by canines. Now, foot and mouth disease is another disease targeted for elimination, or some refer to it as regional eradication, but I will stick with the term elimination in this case. And we can see here the situation in 1988 when the effort to eliminate foot and mouth disease got underway. Chile was the first country to be able to verify that it was no longer endemic. There's no longer transmission of FMD there. In 2011, a number of other countries were able to advance in various ways, some with the vaccination for the disease, some without, and some countries which have a status which is unconfirmed as to whether or not FMD is today present, such as Colombia in 2019. And countries where we don't really know the status, such as Venezuela. The work for FMD elimination is undertaken by PAHO, and its center, Pathophysiology, as I mentioned. And here they describe the set of tools and activities that they undertake with the countries reporting livestock cases. And you can see it ranges from a very effective vaccine that was developed in the last I think 15-20 years, various laboratory tools that are made available to the countries and the training that goes with it, the vaccines, of course, distance learning programs, financing of technical cooperation, so the countries that are having a suspected outbreak or cases can receive cooperation as needed from experts from outside their country, and epidemiological tools which are in place to aid the countries to track cases, and working through plans of action that countries have developed using technical guidelines that were developed, mapping tools, working groups, and conferences which occur and work each year to move towards elimination of FMD. And then the stakeholders that are involved here and the strategic partners are, of course, multiple and range from both national and local government officials, those in animal health, in the public and private sector, livestock production councils, and then at a higher level, the ministries of agriculture and livestock, sometimes ministries of health. The government of Brazil has been very focused on this work, and the Inter-American Development Bank supporting it. There is, again, a relatively recent paper, which is, I think, one of the few that I came across in my brief search recently, that takes a One Health approach to looking at a number of pathogens of infectious diseases, including foot and mouth disease. And this is a study that was done in a number of countries in Southern Africa. So if you're interested in this particular theme, I encourage you to look at this One Health connection with respect to foot and mouth disease, the interaction between domestic animals and wildlife, and how there's an interaction which it represents actually a challenge to conservation efforts, as well as, of course, to eliminating the disease. Now, there are a number of challenges to accelerate disease elimination, and our colleague Dr. Marcos Espinal, I think, has nicely summarized these here. Again, I won't read through them, but we've got movement of populations, human migration for various reasons, be it climate change, be it civil war, be it economic issues, emerging and re-emerging infectious diseases. The fact that many countries have really not fully prioritized a number of diseases for elimination, but which must occur in order to be successful. In some cases, we need to understand the epidemiology of disease elimination better for some diseases which are, I believe, possible to eliminate. We have a donor fatigue, which always is an issue. So many demands for humanitarian assistance, for public health. Will there be enough funding allocated by donors in order to accelerate elimination? So those are just a few of those challenges that we face. Well, one way that PAHO has been developing over the last 2 or 3 years is to establish an integrated and a sustainable approach towards ending these communicable diseases in the region and a number of related conditions. You can see a photograph here of an indigenous girl who's holding the head of a wild boar species, and just I think very nicely shows the connection here to our theme of One Health, and how the exposure of poor communities and the people within them puts them at high risk, and shows us where we need to focus our efforts. Now, I had mentioned in a couple of slides in order to establish a region-wide disease elimination effort or initiative, we are going to have to build on the successes that we've had. I mentioned the successes with a number of the vaccine preventable diseases, and recent successes with ending mother-to-child transmission of HIV and syphilis in 7 Caribbean countries. The 4 countries that have eliminated onchocerciasis in the region, only 2 more left. 27 countries in the region, states and territories, now malaria-free. And with respect to FMD, as of 2017, nearly 96% of the bovine and buffalo populations in South America are free of this disease now. And and then continuing with our human rabies cases, as I mentioned, 5 cases in the last year, 9 cases acquired from canines, and 9 acquired from contact with wildlife. So the Elimination Initiative is one which is going to incorporate, as a part of the integration of work that needs to be done, universal healthcare and particularly primary healthcare. The primary healthcare system is really key to providing the services and also screening and surveillance that needs to be done for the elimination of targeted diseases. And there's certainly a rich number of, a large number of global and regional strategies and regional plans of action that have already been developed for most of these diseases and conditions. So it's a question of looking at how they can be integrated or better integrated, looking at how we can sustain the work and step up the work towards elimination over certainly the next 10 years and further if needed, so that countries can be cognizant that not only they can eliminate disease X over here or disease Y over there, but if things are better organized, there may be ways of, particularly through the primary healthcare system, to provide opportunities to tackle additional diseases, to speed up the efforts to eliminate some through coordination between different programs within ministries of health and with external partners. So the framework that has been developed is one where we really are trying to envision and share this vision with not only ministers of health, but with heads of state about having future generations in their country free of a number of communicable diseases. You'll see we're looking at conditions over 30. And with the goal to try to eliminate the public health threat that these represent, either by eliminating transmission or eliminating them as a public health problem. And with some targets, which are always, of course, going to be very specific to the disease that you're talking about. But in general terms, we're talking about stopping transmission where possible, ending mortality or ending premature death, ending illness, and ending disability, or a combination of these for the disease, depending on which one we're talking about. In order to carry this out, there are 4 lines of action which have been identified. I mentioned the importance of primary health care, but it's really the integration of health services at all levels that really need to occur to have the success that we need. And as we saw with the onchocerciasis program, we really need to continue and improve the ability to capture and generate strategic information, analyze it, and disseminate it to decision makers as a part of the elimination effort. Tackle the environmental and social determinants of health, whether those are water supply and sanitation improvement, solid waste management, or changing the interaction between communities and the local environment. And working, of course, with those decision makers at the local level and the national level through governance, stewardship, and investment of funds. Now, we talk about a number of diseases as candidates for elimination based upon successes in the past, successes in the ongoing in certain countries, and always depending upon working on the not only the disease and condition itself, but the environmental determinants of that disease or condition, understanding the routes of transmission and how the routes of transmission can be broken, how we address the sequelae of infection, for instance, an individual infected with Chagas disease at a young age may or may not have an acute infection and have access to treatment, but later in life, when they are older, come down with chronic Chagas disease pathologies and are at risk of premature death. And the technologies that we have, which again depend upon the disease and the clinical and field know-how we have for each one. We are, though, as a health organization, the Pan American Health Organization certainly is adept at working with ministries of health and those already working in health. It's going to be important for this exercise to also be able to work multi-sectorally and interprogrammatically with other ministries be it environment or agriculture and livestock or public works, etc., in order to carry out the range of interventions that we may need depending on the disease, be it immunization, screening, case finding, treatment and care, vector control, education, etc. So the focus has to be on looking at this as a public health challenge, looking at each disease through the life course and where can interventions be successfully made to prevent transmission, stop premature death, reduce the number of cases of illness, and prevent or correct disability. And so it involves a life course approach, which is referred to in certainly in social and health sciences. So for each intervention that's developed in the elimination process, we need to ensure and understand what can be done in each of these phases of the life course to reach our elimination goal. I've mentioned, I think, a number of the pillars for this already for the work of elimination, and particularly the effort to integrate programs within ministries of health and with healthcare agencies, involving certainly, for example, a level of vertical and horizontal integration, which may not have occurred or occurred strongly enough, improving surveillance and mapping to gain that strategic information we need, not only to know that disease is under control, but is it meeting the criteria of elimination? Can it be verified? Monitoring and follow-up, the use of tools, and of course the political commitment and the partnership with communities and stakeholders to make integration possible. Now here is, this is a draft of the approximately 37 diseases and conditions which we're looking at very carefully now, which can be, if these resources are in place, can be eliminated by 2030 in either in the region as a whole or in more and more countries within the region if we're not successful in doing it at the entire regional level. So eliminating a number of diseases is a public health problem. Some are already targeted under plans of action, such as congenital Chagas disease and syphilis, for elimination by next year, mother-to-child transmission of HIV. A few years down the road, we're looking at elimination of public health problems, certain aspects of diseases ranging from fasciitis to leprosy, plague, soil-transmitted helminths. I know we have one NTD expert here in the room. And further down the road, for instance, in 2030, targeting elimination as a public health problem of other conditions, hepatitis B and C infection and related cancers that arise with this, HIV transmission, this TB AIDS epidemic, which is so deadly. And then even further down the road, well, tuberculosis eliminated as a public health problem, perhaps that will take us to 2035. There are diseases, of course, that have already been eliminated from the region according to the criteria that have been established, but we need to maintain those. So neonatal tetanus, for instance, is going to have to be maintained. In terms of the transmission side, we look here again on a number of different dates and targets, but what is deemed as feasible for elimination of domestic transmission of Chagas disease. We hope to see the end of transmission of onchocerciasis in Brazil and Venezuela by 2022. Rabies, dog-mediated human rabies. We saw the very few number of human cases we have left in Latin America and the Caribbean now. And malaria also being targeted for elimination, both falciparum and vivax malaria, and bringing into malaria epidemics, be they big or small, in the region. And then the maintenance goals we have to continue at, which are already achieved here, but for instance, through blood bank screening throughout the region from North, Central, South America and the Caribbean, Chagas disease is no longer a threat, transmission of it through blood transfusion, through blood products. Then measles, polio, rubella, and some which are still under discussion, but we have had the luck of not having had urban yellow fever transmission transmitted by Aedes aegypti in this region for at least a decade. And this, we want to make sure that we don't see the reoccurrence of urban yellow fever transmission by Aedes aegypti. So that is a maintenance challenge, but part of the elimination effort. And then finally, targeted for eradication. I've discussed FMD in the domestic bovids, and the elimination or eradication of yaws, which needs to be verified, though it seems to be gone from the region. And then something rather novel, which is still under discussion, but is gaining some support, and that's to eliminate as a public health problem the issue of open defecation by humans, with those who don't have access to VIP latrines or toilets, sanitation systems. We have estimated that around 9 or 10% of the population in the region still practices open defecation. And what can we do in the next 11 years to create conditions so that this practice can be ended in, certainly in as many communities as possible. One of the challenges with people, anthropologists and social scientists have raised, well, what about indigenous communities where this may be an extra challenge? And that may be the case, but we need to think about how we can support this type of effort. Think it through, develop the targets, the milestones, the indicators of at least seeing a decline in the practice of open defecation and how we measure that. And the same for the case of the use of biomass-based cooking fuels indoors, causing indoor air pollution and contributing, of course, to outdoor air pollution as well. But we know these are definitely health hazards for those that live in the home, young children, women who may spend much of their time there, and of course the whole family. So looking for and setting up incentives and conditions to have a substitution so that families can move away from using biomass as a cooking fuel in the indoor environment and replacing it with energy or with a safer energy source is also a goal that we're looking at for the 2030 period. Some may say, oh, these are a bit radical, it may be impractical, but we need to think it through as public health specialists, how this might be done. Again, what are the indicators, the milestones, the resources that are going to be needed to at least progress towards this type of goal, and see how far we can get. Can you imagine if you're a president of a country in which you can see over the last 10 or 11 years that your country, through greater effort and with greater resources available, is able to eliminate a number of these up to 37 diseases and conditions. So this is what we're in discussion with. The countries of the region, the ministers of health, are going to have a chance to discuss this in the fall of this year, and we hope that we'll be able to ground it and make it a reality and find the partners and resources that are needed. Monitoring of this is going to be very important. How can we monitor the progress towards these goals? And we're already, of course, looking at dashboards like this where country by country we can see where their status is with respect to elimination of one or more of these diseases and conditions. We, as I mentioned before, we have the many tools available for many of them, not all, but many of them already available in multiple languages, technical reports, technical guidance documents, and for some aspects of implementation, PAHO, for instance, has a strategic fund which aids countries to purchase everything from insecticides to medical supplies, and even certain items that can help improve water supply and sanitation at the household level, as well as a rotating fund for vaccinations. So again, resources are in place already. Let us apply them towards these goals. Thank you very much.
So thank you so much, Dr. Ault, for that presentation. As the tradition goes, the One Health Academy would like to present to you a flag that's been flown over the Capitol. So thank you so much for your time and sharing all that information with us. We really appreciate it. And now, if it's all right with you, I'll open the floor up for questions. So we have
thank you.
For 2 or 3. Anyone have questions?
You had mentioned that, particularly for NTDs, it requires kind of a multi-sector, multidisciplinary approach. But sometimes you see with a lot of the NTDs, it's mass drug administration without the linkage between, like, really a kind of integrated approach on the program scale. Have you seen, like, actually efforts where maybe the elimination goals or the targets were accelerated because it really came in with a multi-pronged integrated approach, or is it usually kind of mass drug administration alone and then followed up by, maybe identification issues or kind of behavior change? Are they usually, have you ever seen it go in parallel instead of in sequence?
Well, yes.
I'll ask you repeat the question.
Okay. So the question with respect to NTDs, to neglected tropical diseases, particularly those which focus primarily on the distribution of drugs, antiparasitic drugs, and other drugs. Have there been examples of programs that have gone beyond just the simple distribution of these drugs, have taken other actions or activities in parallel, which have either helped accelerate the elimination effort or contributed towards elimination or control of other diseases? So I would say, I think a prime example, I won't say that there are many, but certainly one that comes to mind immediately for me is the efforts with respect to elimination of onchocerciasis, or river blindness, in which yes, the principal intervention is the delivery of Mectizan 4 times a year to all the populations at risk for as many years as it takes to stop transmission. However, in the process of doing that, the teams, the community members that have been working in each of the 6 endemic or formerly endemic countries have also been trained in health education processes, which they've applied not only for onchocerciasis elimination to raise awareness about the importance of taking the medicines, but also about limiting your contact with vectors in the natural environment as possible. And it's also led to, certainly in the case of both Colombia and in Venezuela and in Brazil as well, in particular, the delivery of other primary healthcare interventions by those same community members, so that when they enter the village or the town or the isolated home, they have been trained to not only provide Mectizan, but also to hear from the family members what other health problems are they having. In some cases, the teams, particularly in both Brazil and Venezuela, actually, though their main focus is onchocerciasis, they do screen for and treat malaria, diarrheal diseases, other skin conditions, sometimes treat injuries, at least at the first aid level, refer individuals to the local healthcare system, beyond the primary healthcare system to the secondary level, etc. So the training that they receive, those team members and community members that work with them, is the part where you can see, I think, not only an acceleration of the effort to eliminate that disease, but to build capacity and help improve the health situation of families for other diseases and conditions they face.
Thank you for your talk. I wanted to ask, with the current Venezuela and the humanitarian crisis there, has that postponed the ability for WHO teams to actually get in to work on this crisis, and is it in danger of potentially derailing the eradication effort for that pathogen?
Okay, so the question is, with the current political situation in Venezuela, has this situation interfered with the ability to stay on track in terms of eliminating onchocerciasis or river blindness in general terms? So you may be surprised by the answer, but in general, no, it has not. In the case of onchocerciasis. Now, you may also may well know that Venezuela has been facing a severe problem with malaria outbreaks, malaria epidemics. So that's a different story. That is more challenging, though. With planning and coordination, it has been possible, at the invitation of the Venezuelan government, even this year, for PAHO WHO staff to provide technical cooperation in the country, to go out in the field with the Venezuelan teams and work in hotspots or work on outbreaks, particularly with respect to malaria. Fortunately, though I don't know all the challenges behind it, it has still been possible to continue to import ivermectin free of cost to Venezuela, so that it can be taken to southern Venezuela and distributed to the Yanomami communities there. And that work is carried out by a group called CAICET. It's the acronym CAICET, C-A-I-C-E-T, which is a group of physicians, sociologists, anthropologists, nurses, public health specialists, and Yanomami community members who work together for onchocerciasis elimination, but also to provide all those other parallel health services that I mentioned, screening for and providing treatment for malaria, making referrals, dealing with skin diseases, first aid sometimes, etc. So all that is done by the CAICET teams. And it's rarely that, well, there's really no case where CAICET and its partners have not been able to do this work I'm trying to rephrase it. They do this work by themselves. So it hasn't been necessary for them to ask for external technical assistance in the field for this type of service delivery. And they've had 30 years of experience in doing this, so very good at it.
All right, I'll ask everyone to keep your questions to Dr. Ault after we wrap up, but thank you so much everyone for coming, and please join me again in thanking Dr. Ault for this great presentation.
Thank you.
Please get some more food, plenty more where that came from, so please help lighten the load. And yeah, we updated the website for those that haven't seen, and our next month's speaker is up there. So thank you so much for coming in person, and thank you everyone online. Everyone have a great rest of the month and enjoy the warm weather.
Very nice, and I'll give you thank you.